Okay, so let's go over the questions that you guys had before. They were pretty straightforward. They were sort of along the lines of what I would ask you on the exam. So the first question was one of the most common side effects associated with the use of diuretics, and the correct answer is B, which is electrolyte disturbances. So kidney failure doesn't really occur, but we usually that would be a concern we would have, but CNS depression is not an issue, is not a common issue. Hyperkalemia is just really an issue that may be associated with the potassium-sparing diuretics, but is not for all the diuretics. Question number 2, hormonal side effects occur with which of the following? The correct answer is C, spironolactone. And remember, we talked about that spironolactone was an aldosterone antagonist and also a weak progestational. And then actually Angela had asked the question or made the comment about one of her patients was being given that as a transgender patient. 3, which is the following is the most potent diuretic? And the correct answer here is furosemide. So we have thiazide and chlorothiazide. Both of those are thiazide diuretics, which are usually the least potent. And then we had spironolactone, which was actually the that potassium-sparing antagonist. And remember, furosemide basically is acting on the loop of Henle. And finally, the fourth question, which is the following is converted to an active metabolite? This is one of the things we talked about right before we left for lunch, which was methyl dopa. The correct answer is A. And methyl dopa, remember, is taken up into the neuron, is actually converted to methylnorepinephrine. Clonidine is a direct-acting drug. So it is acting directly on the alpha-2 receptors. Now, here's a good example of what I told you about the other day. We have not covered reserpine. So one is you don't necessarily know what reserpine does. We haven't covered it. So you could probably eliminate that from this question. And then spironolactone, is a diuretic. And spironolactone is not converted to it, but its progestational aspect is part of its own binding there. Okay, so there was the 4 questions that we had. And you'll have 4 more at the end of this session. And then we will go over the answers to the 4 for this session. We'll either go over them probably first thing in the morning, and then so you can have those. All right, so let's go back to the slides. And so far, let's see, let me get back to the screen share. Okay, so the drugs we've talked about so far as antihypertensive drugs, we've talked about diuretics. We have talked about the centrally acting drugs. We've talked about the beta blockers, the alpha blockers, and then the mix blockers, okay? And now we're going to talk about a group of drugs which actually have very limited usefulness. We're not going to see these drugs used for people that have stage 1 hypertension. We're typically going to see these drugs used with stage 2. These are usually people that are that have not responded to the drugs, to regular drugs. They've been sort of refractory. Their blood pressure is still elevated. The reason we wait for these particular drugs is because their side effect profile is generally not very pleasant. And so really we're making a benefit risk where we're willing to take on some side effects. The downside of it is that the really question is that the side effects the side effects may result in the patient being reluctant to take the drug and staying on the drug. So we refer to these as sympatholytics because they are interfering with the sympathetic nervous system. We actually have, you could, in theory, call alpha and beta blockers sympatholytics or even centrally acting drugs, but these are working primarily on the presynaptic neuron and interfere with the sympathetic nervous system. We have basically the 2 drugs. What we have is reserpine, which has been around for a long time, and Rauwolfia was very similar to reserpine. These two drugs are very similar in their action. Right here, we're going to use reserpine as our prototype drug of these drugs, and the other drug is guanethidine. And with guanethidine, what we're going to do, guanadril is similar to guanethidine, so these two are sort of similar. Okay, all right. Let's start with reserpine. Reserpine. Now, what it's going to do is reserpine actually has to be taken up into the neuron. And what it's going to do is it's going to actually deplete norepinephrine from the neuron, because what it does is it blocks the storage of norepinephrine in the storage granules. So if you remember, let's see if I can draw this out here with the pen. Let's get color and then get. Okay. So what we have is it is not cooperating with me. All right, let's see if it will cooperate now. All right, so what we typically have is, in my pen, oh, there it is. Okay, so we typically have the neuron. Well, here's my problem. I am off the slide. So we have the neuron, presynaptic neuron, and remember that we have those vesicles. So I'm really simplifying it. So what happens is norepinephrine gets released into the synapse. Forgive my etch-a-sketch drawing here. The norepinephrine will then be taken back up into the presynaptic neuron, and then the norepinephrine goes into the cytoplasm, and then the norepinephrine then gets taken back up into the vesicle where it's stored until it's released again. So remember, with the sympathetic neuron, it looks like a Pinocchio E that he's been lying with a long nose. But so what happens is the way we terminate the action of norepinephrine is basically it gets taken up out of the synapse up into the presynaptic neuron. When it's in the presynaptic neuron, of course, it can't interact with the postsynaptic receptors. Then we restore it and we basically reuse it. Well, what reserpine does is reserpine blocks this storage right here. Okay, and so if the norepinephrine, so by preventing the storage, ultimately what it's going to do is deplete norepinephrine, because if the norepinephrine is not taken back up into the storage vesicles or the storage granules, basically what's going to happen, it's going to be broken down by monoamine oxidase. So the net effect is that reserpine prevents the storage because it inhibits the transport system, which is an amine transport system that basically carries it into the granules. So by blocking that, the norepinephrine can't be stored, and over a period of time, what happens is the body gets depleted of norepinephrine. So therefore, when the nerves fires, there's not a lot of norepinephrine that's being released. So one of the things that's a consequence of this is that this is not going to be a quick response. It takes about probably 2 to 3 weeks at the dosing that we normally use with reserpine. And so basically what that's going to do is that's going to take about 2 to 3 weeks. So we're not going to expect to see a drop in blood pressure for immediately. So we're not going to use this a very rapid type effect, and it's going to take a while for it to actually occur. The problem is, think about this. All right, so you're depleting the norepinephrine, and one of the big issues that's going to emerge is that, think of all of it. This is not going to be limited to just the noradrenergic nerves around the blood vessels. It's going to be all over the body. So we're going to get a depletion of norepinephrine all over the body. Reserpine can get into the central nervous system. So one of the big things that we're dealing with is right here. One of the big things that we've got to be concerned about is that we can have some pretty prominent CNS effects. Okay, and what we do see is we see sedation. Norepinephrine is usually thought of as more of an alerting type transmitter. One of the big things here is depression. So this is a major concern we'll come back to in just a moment. Nightmares can occur. These are all CNS-mediated effects, which are associated with the depletion of norepinephrine from noradrenergic neurons in the brain. Another thing, when we first started using reserpine and Rauwolfia, one of the big things we saw was that a lot of people complained of GI effects. We saw a lot of nausea, vomiting, and diarrhea. These drugs are pretty irritating on the stomach and the GI tract. And in fact, that was one of the reasons that individuals a lot of times wouldn't tolerate them, especially at the doses that we were using, is that it just created too much. It just made them sick. We saw that it did lower blood pressure. And when it lowered blood pressure, a lot of time we got fluid retention. So we got a lot of puffiness, a lot of edema. Sexual dysfunction was a big issue. Another major reason why people quit taking it here. Heart rate slowed down because we depleted the norepinephrine in the heart. We had orthostatic hypotension because the blood pressure dropped, and the body couldn't respond with reflexes to sort of offset that because of the norepinephrine being depleted. Another thing we saw was very, very severe nasal congestion. And in fact, the nasal congestion, you think about, here in Georgia, we have a lot of pollen that's out right now, and people are going around with, just congested because of the pollen, feel miserable. But this drug would actually cause nasal congestion so severe that a lot of times people would just quit taking it. That the nasal congestion is not a life-threatening situation, but if you think about if your nose was as really stopped up as you've ever had it stopped up, this was a very interesting thing there. So that was it. By the way, just let me go off on a tangent. It was interesting about clonidine. Clonidine was actually being developed for as a nasal decongestant. And during the development, what they discovered was that people that were using it as a nasal, in the clinical trials, that when they used it as a nasal decongestant, what happened is a side effect that they saw was hypotension. So they discovered that clonidine was not going to be effective as a nasal decongestant because it tended to drop people's blood pressure too much. So it was actually developed again, a change in the dose and everything. Was actually developed and marketed as a hypotensive agent, although it started off as a decongestant. So we have some pretty serious concerns here with the side effects. Again, the norepinephrine is depleted all over the body. So we see from a compliance standpoint, one of the big things was the GI effects made people just not feel good. The nasal congestion was not life-threatening, but basically was unpleasant enough that people quit taking it. The sexual dysfunction was a significant thing, especially in younger patients. But again, CNS depression, people were just sort of wiped out and depressed when they took the side effects. So we were not seeing reserpine being used as a first-line agent for treating hypertension. We were seeing it being used, in patients that were refractory and that didn't respond to, say, such as a diuretic. So, but we actually, when I was at Charleston doing my postdoc, which was in 1979 and 1981, we as a faculty actually was literally looking for having a discussion of whether we were going to even treat or even teach reserpine anymore. Just like we talked about last time we met, the ganglionic blockers. Those were too much. And we just said, hey, here's the problem is this, we don't see this drug. Do we really see this drug used that often? And what we discovered was it was still being used, not near as frequently as what we saw with a lot of the other drugs. But the big thing was that we did see that it was relatively cheap. We did see that for example, that a lot of clinics, it was generic, and a lot of clinics basically could use it, especially in low-income patients. And another big thing is that they reduced the dosage. So when it first came out and was being used more frequently, we had higher dosages. but we found out that some clinics use it. In Charleston, we also saw a lot of people coming from other countries that reserpine, that when they would come to stay in the United States for a while, maybe try to get prescriptions filled and so forth. Many of them, we saw several people that had reserpine. And Charleston was one of these, cities that's sort of a port city. We saw a lot of people coming in here, and we actually, we said, okay, we need to still teach it. But again, this is not one that is as mainstream as what you see, but it's still used, and we still see people that do okay on it. But these are the people that the side effects we're able to manage, usually by low dosages. One of the big things that did come out, though, is that we did understand that depression, as we recognized more and more about the significances of depression, one of the things that we would see is that this drug did produce depression. And so what started happening was we started saying, actually, if the person starts showing any sign of depression, discontinue the drug. Get them off the drug, put them on another drug, because actually this depression could be pretty severe. Just about like, I think this was probably produced a little bit more severe depression than we saw with clonidine, although clonidine can do that. We also came back and said, if the patient is depressed, well, one of the things we taught general practitioners was basically that the patient may not come in and tell you depressed, or they may not even tell you that they're seeing a psychiatrist. But we did say, if they're we started telling them if they're taking antidepressant drugs, then one of the things that you need to look at is to see, why are those antidepressant drugs being given? Is this probably an index or an indices that they are being treated? They may have depression. So that's one of the things that we said. If we know they're depressed or they're on an antidepressant drug and it looks like they're being given the antidepressant drug to treat depression, then do not use it in those patients. Discontinue it if they start showing signs of depression, at the first sign of depression. We don't see as many monoamine oxidase inhibitor drugs used. I'm just curious, of you guys, do you have any patients on monoamine oxidase inhibitors? I usually ask this every class, just curious. We see a few, very rarely we see a patient on an MAOI, and it's usually one. So you guys are not seeing a whole lot of it either. I will see one every now and then, but most people, and actually they're very good they're pretty good drugs in the right patient. But we've seen over the years, because of the bad rap they've got, typically a person on an MAOI is one that is pretty much everything else has not worked. So it's sort of like the last resort. But over the last one I saw that was on an MAOI was probably 6 or 7 years ago. The guy did great on the monoamine oxidase inhibitor until he was the guy I told you about, that the doctor gave him an antidepressant. Gave him a decongestant, and he ended up stroking out. But the drug worked very well for him. It was just the drug interaction that created a problem where he became a quadriplegic. But I think most people are afraid and are reluctant to use MAOIs mainly because of that. But we don't want reserpine used with a monoamine oxidase inhibitor or a tricyclic antidepressant. What can happen is, by it blocking the amine transport, it can prolong the effect of these of the norepinephrine, and so you can get a hypertensive crisis. Off-label, we've seen reserpine used in people that are in agitated psychotic states, schizophrenia. It's not a very common use, but it has been used in a few instances. We have much better drugs for that. But reserpine is one of those that, despite, again, the downside of it, it takes a while to develop the hypotensive effect. Secondly is that we have these side effects that can affect compliance, and we have side effects that can be serious. So again, we see this probably in people. We have some people that have been on it for a long, long time, and they've just kept them on it. And we see it sometimes when other drugs, they're usually stage 2 or in the upper realms of stage 1, and nothing else seems to work. So let's move to the other sympatholytic, which is working slightly different. This is guanethidine. And we refer to this drug as a adrenergic neuronic blocker. Okay, and so we're thinking about that this drug is blocking at the adrenergic neuron. Okay, and that's exactly what we see. One is that it has an action where it inhibits the action potential that comes down. So when an action potential comes down to make the nerve fire to release the transmitter, norepinephrine, the sympathetic nerve, basically what we find is the presence of this drug inhibits that action potential. So the signal to release transmitter is dampened. The other thing is that it will, in addition to releasing less norepinephrine, what we also see is that it will prevent the uptake of norepinephrine, reuptake of norepinephrine. So the norepinephrine stays out in the synapse and actually gets broken down, or even when it gets, it's broken down usually out in the synapse or floats away. And also the drug actually gets taken up into the neuron and will go into the vesicles and physically displace norepinephrine. So what you have is that it basically reduces the amount of norepinephrine. It reduces the amount of norepinephrine that can be released by two mechanisms. That it depletes the norepinephrine, bumps it out of the storage vesicles where it's broken down, and also it releases it dampens the stimulus coming down. This drug is considered sort of the last resort. This is where typically the patient is on 2, 3, maybe even 4 other drugs to try to lower their blood pressure, and nothing has happened, or that we haven't got it low enough, and so we will then use guanethidine. This will take about a week for the effect to occur because it's going to eventually deplete the norepinephrine levels by displacing the norepinephrine out of the granules. This reserpine actually blocks the transport of norepinephrine into the storage vesicles. The guanethidine blocks the reuptake into the neuron, plus it displaces it out of the storage vesicles, and when it's displaced out of the vesicles, it's broken down by monominoxidase in the cytoplasm. So again, I've got the term severe, which is the term they've used, but this is generally probably a better term here would be that this is left to maybe stage 2. Hypertension, or we see it refractory hypertension. Say it's stage 1, and it's classified as stage 1, and it's just not responding to anything else. The main problem with this drug is that its side effects. Again, this is the biggest issue, is that both with reserpine and with guanethidine, the side effect profile is usually one where that a lot of patients will have a hard time complying with it unless, we really are talking to them about, we have to get your blood pressure under control because over the long term, it's going to create problems. Most of the effects are simply, again, extensions of the sympathetic blockade. So they're impaired reflexes. So they have a lot of orthostatic hypotension. Their body can't adjust. Get a lot of fluid retention. We never use this drug or reserpine alone because we do get fluid retention. So we generally have to have a diuretic about that. We get, people just don't feel good on this drug. They have sexual dysfunction. So quality of life and everything is just not really good. So that's why pretty much this drug is just reserved for those patients that are not responding to other combinations and their blood pressure is high enough where we know that we need to try to get it under control, because long-term effects of it that way is going to have some significant impact, some significant aspects there. The other things we have to be careful with, especially with guanethidine, is we have to tell the patients not to use over-the-counter any other sympathomimetic agents, okay, especially over-the-counter. Things like cold remedies, and we used to have some of the diet aids were sympathomimetics. Those have been taken off the market. And the reason for it is that this drug, by its actions on norepinephrine, will actually cause norepinephrine levels to increase. and a combination of these other sympathomimetic agents and the norepinephrine levels, in the presence of both, the norepinephrine levels increase, and it can produce a hypertensive crisis. And people can stroke, or people can develop some severe arrhythmias. So a combination of guanethidine and other sympathomimetic agents can elevate the norepinephrine levels, and plus the actions of the sympathomimetic agent, to the point where the blood pressure really goes through the roof. Now, here's an interesting one. This is just give you an example. The oral contraceptives can actually blunt the hypotensive effect of this, because it can interfere with the actions. So this drug, guanethidine, unlike reserpine, does not get into the brain. Okay, guanethidine is sort of a big molecule. So the thing about it is that the guanethidine actions are not, the guanethidine actions may be blunted by the oral contraceptives. So that's an issue. But here's another one, this last one. This is more of a concern with what you guys would be concerned with, is the tricyclic antidepressants. Tricyclic antidepressants can interfere with the hypotensive actions. Now, why does the tricyclics interfere with the effects of guanethidine? Why doesn't guanethidine interfere with the effects of tricyclics? And the reason for that is what I just talked about. The tricyclic antidepressants, their major site of action is going to be in the brain. They produce their antidepressant by interfering with or elevating norepinephrine levels in the brain. Okay? So guanethidine, we're looking at not a central action, we're looking at a peripheral action. So guanethidine is not going to interfere with the tricyclics, because their site of action is primarily in the brain. And so what the situation is that since guanethidine can't cross the blood-brain barrier, it can interfere with the tricyclic actions. But the tricyclics, when you take a tricyclic, the patient takes it and it's absorbed and it goes through the peripheral circulation. So the tricyclics can interfere with the guanethidine, because they can prevent the guanethidine from getting into the neuron to displace the norepinephrine. So the reason this occurs, or this interaction occurs, is because tricyclics work in the brain, guanethidine can't get there. Guanethidine's effects are inhibited because guanethidine works in the periphery, and both the tricyclics and the guanethidine would be there. Okay, so sometimes this is always a good example of, sometimes the reason we have a specific interaction with a drug may be as to where the site of action is and where the drugs, if guanethidine could get across the blood-brain barrier, then basically what we would see is that guanethidine could interfere with the tricyclics. So now we've covered pretty much most of the drugs that have interfered or have an interaction with the central nervous system and the sympathetic nervous system, okay? Again, most of these drugs have been around for a while. We've used them quite frequently. What we've actually seen is that the use of these drugs has decreased because of some other drugs that have come out. And we're getting ready to talk about those in just a moment. But before we go there, let's talk about a group of drugs which are often used with these other drugs. And these are what we call vasodilating drugs, okay? Vasodilators are going to act directly on the blood vessel to cause the blood vessels to dilate or open up. So in a hypertensive patient, we have the blood vessels are constricted, which is creating an increased pressure. So the idea here is that we can relax the blood vessels, so it makes it easier for the blood to flow, and that decreases pressure. Now, some people actually include the alpha antagonist as vasodilators, because they act on alpha receptors, and the alpha receptors are on the blood vessels. So I included them as alpha antagonists, but some texts will actually say, these vasodilators are these drugs, since they're acting mainly on the blood vessel, they're vasodilators. But the way that I teach this is that we're looking at drugs that lower blood pressure through a direct action on so we're looking at a direct action on vascular smooth muscle, okay? So what they're going to do is, by relaxing that vascular smooth muscle, basically what's going to happen is that allows the blood vessels to dilate, which decreases the pressure there. Okay, so the reason I separate the alpha antagonist is because those are acting directly on a receptor, whereas these other vasodilators are not acting directly on a receptor. All right, we have two drugs. Probably the one that we see used the most is hydralazine. The other drug is minoxidil. But again, both of these are orally effective. We do have other vasodilator drugs, but they're not orally effective, or they do not have a long duration of action. But these two in particular are effective if taken orally. They will cause vasodilation. Now, here's the problem with vasodilators. And whereas all of the other drugs that we talked about, for example, you may see people with a diuretic using only a diuretic. You can see people on an alpha or beta blocker or a mixed blocker using only those agents, but a lot of times they will have that in a vasodilator. And these other drugs we may use in combination. Definitely with guanethidine, we've got to use several other drugs. We would already have used several other drugs. But we can't use vasodilators by themselves. It's just not possible. And so I've got never use it. It's not because it creates a problem, but the real issue is this first point, is the vasodilators, they drop blood pressure, but what happens is your body's reflexes actually antagonize the effects. So if you give a vasodilator, your blood pressure drops and your body goes, oh, we need to raise blood pressure back up. So what it does is it activates reflexes and actually increases the blood pressure and overcomes the vasodilator. So that's why we can't use these drugs alone, is because your body actually antagonizes or reverses those effects. So vasodilators, other than if we're just using it for a short-term thing, but vasodilators for chronic hypertension always require other drugs. And we'll talk about some of these combinations just a little bit. These vasodilators also can be used, for example, if somebody came in and came into the ER and their blood pressure was sky high, maybe it was due to something else, we'll use these vasodilators to lower their blood pressure. So they can be used chronically with other drugs to lower blood pressure. That's what I mean by uses include hypertension. If somebody shows up in the ER with their blood pressure spiking really bad, maybe they've had a stroke, maybe they had a brain injury, maybe they've been on methamphetamine, we can use these vasodilators to get their blood pressure down. And the other thing we do is what we call hypotensive surgery. Sometimes when the surgeon is going into a really vascular area, as they're cutting into that tissue, they're going to cut into blood vessels, which is going to create some bleeding. And the bleeding can sometimes, you're always concerned about the bleeding from a standpoint of loss of blood, but from a surgeon standpoint, another thing about bleeding is that if it's bleeding a lot, he or she can't see. So we do what is called hypotensive surgery, which is we lower blood pressure, which means there's less bleeding. So sometimes when they're doing surgery, for example, in the spinal area or in a couple of other areas, they may give you these vasodilators to drop your blood pressure a little bit. And by dropping the blood pressure, that reduces the bleeding. So as I said a moment ago, the two that I've given you as examples, both of those are orally effective. Anytime we're dealing with treating chronic diseases, one of the things that we need is we're going to need an oral medication. We can't have people coming in, they can't walk around with an IV bag, and they can't come in every day and let us give them a shot every day in most of this oral things. The drugs are effective. They will drop blood pressure, but one of the things that we see, as I said before, is the body can offset that. So they may antagonize. So if we take, for example, hydralazine by itself, my blood pressure may drop down 10, 20 millimeters of mercury, but in a very short order, in a matter of minutes, my reflexes would kick in, my heart rate would speed up, and other reflexes, the baroreceptor and so forth, would try to bring my blood pressure back up. So we have to use other drugs to block those reflexes. So some of these side effects are due to the pharmacology. So one thing is we get tachycardia. When you drop blood pressure, your body responds by elevating your heart rate. There's the tachycardia. If you drop blood pressure, I've talked about it before, we get fluid retention. So one of the big things with fluid retention is basically what we find is that by decreasing the perfusion of the kidneys by dropping blood pressure, that causes us to retain fluid, so we start getting peripheral edema. We get, fluid accumulating, especially around the ankles and lower extremities. Headaches can occur. The vasodilation up in your brain can increase pressure, cause headaches. The flushing is due to vasodilation in your, under the skin, in your face, and so forth. The biggest thing we see is hypotension, too much drop in blood pressure if we use too much of a dose. So most of these side effects are dose dependent and are directly related to the pharmacology of these drugs. Now, one difference is we do see with this drug, there's a few drugs that can produce drug-induced lupus, and hydralazine is one. And what we find is that when they first put hydralazine out, when it was first released, they were using very high dosages. That used to be what we would see all the time is for a lot of drugs, the drug companies would approve high dosages, or the drug companies would release high dosages or get them approved to the FDA. And those high dosages, one of the things that you would see is basically is that the idea is we want to get blood pressure, we want to make sure it works. And so we'll deal with the side effects later. But what they discovered is patients that were getting doses of 400 milligrams per day we started seeing lupus cases develop. It was reversible. But so one of the things that we see is we don't like to go above 400 milligrams per day because of the chance of developing lupus. Preferably, we try to keep under 250 milligrams per day. So this is one of these drugs. One of the unusual side effects is a lupus-like syndrome. Now, minoxidil, basically, it was orally effective. We typically will use hydralazine for most things. Minoxidil is pretty much reserved for either people that are not responding to other drugs and or have really severe hypertension. And one of the reasons is that basically, let me answer Geraldine's question here. Okay, so on the previous slide, before I go into minoxidil, let me go back and pick up this question. So you asked the question about on the previous slide, which was actually this one. So hypotensive surgery is where what we want to do is we lower the blood pressure, and we use these vasodilators mainly because the vasodilators we can control their control their duration of action. They have relatively short durations of action, and we can infuse, or even if we gave it orally, it's a pretty defined response. But the idea is by lowering blood pressure, it cuts back on bleeding. So that's where that's why it's called hypotensive surgery. It's basically we're lowering blood pressure, which means there's less perfusion into the area. So there's less bleeding, which allows the surgeon to be able to see, and you don't get a lot of bleeding into the area. So that's what that is. Okay, so back to minoxidil here. So this drug basically it probably has more side effects than the hydralazine, or they occur. Same type of side effects in general, but they tend to occur more. We get the fluid and water retention, so we get the peripheral edema. Almost always have to use it with a diuretic. It activates the reflexes, and the reflexes, if you look back at the previous slide, the reflexes include the tachycardia. The flushing and headaches could also be part of that. But the unique thing about minoxidil is one of the side effects we saw was hypertrichosis. Hypertrichosis is hair growth. And so one of the problems with minoxidil, and that's also accounted for why it's sometimes not used, especially in women, is it caused hair growth. Okay. They would get hair growth on their face, and in where a lot of males would get hair growth. What they've discovered was, again, this is another one of the side effects. To tell you the truth, is the company probably make more money because of this side effect, because what they discovered and they marketed is they have used this to treat male pattern baldness. And male pattern baldness also occurs in females. So the hair growth, which is from a hypertensive standpoint, or using it to treat hypertension, the hair growth was a negative because patients don't want to take it, especially women, and experience hair growth. So that was one reason we didn't use it. But on the other hand, from a standpoint, especially with chronic use, on another hand, what individuals do is they now use it to treat male pattern baldness, take advantage of this side effect. Now, when it's being used to treat male pattern baldness, what do you think the major side effect of it is there? Hypertension, right. We will use this there's been a number of products that they use to apply topically, and by applying topically, that would prevent, it decreases, the systemic absorption. So what they're doing is basically the hypertrichosis apparently appears to be stimulating the hair root to make it grow. And so that is why the idea is if we put it on topically, we're applying it right to the hair root, which we believe is where it may be working. So that's why it works topically. If we, I'm not sure if no one ever developed or tried to develop minoxidil as a patch for treatment of hypertension. But it works topically because it's being applied directly to the hair root. So that's why it works that way. Okay. Again, another example of of a drug side effect where it's being taken advantage of to be used. But again, this has been used as a thing. And Abdullah, that is also correct. The idea is that there seems to be some stimulation of the hair root, but also the issue is it improves vasodilation and therefore more nutrients going to the hair. So it's a combination, the vasodilatory thing, but there's probably something else that is there. So your hair when applied topically, you're going to get a stimulation of blood supply there, but there apparently needs to be something else is added into that. Okay. All right. So now let's move to sort of we almost can include it modern medicine here. So we started seeing this is where you can tell your age because I was at Charleston. So that was in 79 to 81. And this is when we started hearing about the ACE inhibitors. And I remember there were some headlines about some of the patients that had been treated for the first time with captopril, which was probably our first angiotensin converting enzyme inhibitor drug. Okay. So the big thing is, if you think of all the drugs we've talked about, we had diuretics, we had CNS acting drugs, we had beta blockers, we had alpha blockers, we had mixed blockers, and we had vasodilators. Those were pretty much the mainstream of treating hypertension until the ACE inhibitors came out. Okay. So the first ACE inhibitor that was released was captopril. And I'm not even sure if I've got all of these ACE inhibitors that are listed that are still there. But captopril came out, and then we started seeing enalapril. Enalaprilat is a derivative of enalapril. We have lisinopril, quinapril, benzapril, benazepril, ramipril, lisinopril, and moxapril or moexapril. So most of these are ending in pril. Okay. So captopril was the first drug that came out. All of the rest of them are the secondary and even maybe tertiary ACE inhibitors. They are called ACE inhibitors because of their mechanism. It's angiotensin converting enzyme inhibitors. And what they do is they basically act, if you remember the renin-angiotensin system, is we have angiotensin 1 gets converted to angiotensin 2, and that is done by an enzyme known as converting enzyme. So these are called angiotensin converting enzyme inhibitors because they inhibit the enzyme that is responsible for the conversion. Angiotensin 1 doesn't really have any physiological or pathological effects. angiotensin II does. So the active component of the renin-angiotensin system is angiotensin II. Now, prior to these ACE inhibitors, the way we interfered with the renin-angiotensin system was we used beta blockers or we used CNS acting drugs. Both of those class of drugs interfered with the renin-angiotensin system by decreasing the release of renin. Basically, by reducing the sympathetic nervous system's activity, that decreased renin. So we interfered with the system by interfering with the renin, which was released from the kidney. But then these drugs now interfere into the system by blocking the converting enzyme, which prevents the conversion of A1 to A2. It's a competitive inhibition, and so the way we see this is, the nice thing is this lowers blood pressure, but it doesn't seem to affect the heart. So all of the other drugs, except for the diuretics, basically when we had effects, they would either indirectly or directly interfere with the heart. So that was an advantage of these drugs, is that we didn't have as much effects directly on the heart that inhibited the heart rate or the cardiac output. So that was a big thing. The other thing is that the side effect profile of these drugs was so much improved. So these worked, and in fact, what we saw was that these drugs came out like a lot of other drugs. What occurred was that they were expensive, they were name brand. So what we saw was basically the ideal patient that went on these drugs was white male hypertensives. It seemed to work very well. Many people didn't think that it worked as well in blacks or in other ethnic groups, and that was just really misinformation. So now we see these drugs used all the time. They lower blood pressure, they're effective. They can be used as monotherapy. And you're going to see that we also use these ACE inhibitors for other disease states that we'll talk about between today and tomorrow. Okay, other cardiovascular things. So therapeutically, they work. The side effects, one of the things is in some patients, we may get too much hypotension, too much lowering of blood pressure. That can occur especially in patients that are taking diuretics. So again, this is dose related and we may just need to lower the dose. This can occur if people have low salt intake. They tend to be more susceptible to this. And we do have a small population of patients that seem to have really high renin levels. So it seems that the renin-angiotensin system is really hyperactive. So in some of those patients, when we give them an ACE inhibitor, we get a pretty profound drop in blood pressure. Probably the most recognized side effect of these drugs is cough. And we see estimates of basically the incidence of cough is typically what I see given is that cough occurs probably in around 15% of the patients. I suspect it may be a little bit higher than that, but this is the most common thing. It is it varies a little bit between each of the different drugs. Each of the new drugs when they came out, almost all of them cited that their incidence of cough was lower than captopril. And what you actually see once the drugs are on the market is, I'm not sure it's really that much different from captopril. Have any of y'all had a patient or know of anybody that's on one of these drugs that has developed this cough? Okay. One of the things is the thing with the cough is this can be very irritating. And again, we have a large number of people that don't develop a cough, but when they do develop it, sometimes it may be a reason for noncompliance. I've been around some people that have had this cough, and what happens is when you're first around them, it basically can be sort of annoying. They're not coughing intentionally, and sometimes they become very self-conscientious about it. So that's an issue. One of the things that can occur with these drugs, it's a rare condition, but it's called angioedema. And what angioedema is, it's basically, the term means basically swelling around the blood vessels, but you get leakage of fluid out into the tissues. But angioedema is, our biggest concern is that can occur up around the mouth and the face and the throat. And so when they develop this, again, very rare, but we do see that it can potentially be life-threatening. Let's see, Jason, does the cough have anything to do with the fact that angiotensin gets converted in the lungs? It's not necessarily. It appears to be related to potentially some effect on bradykinin. And it appears to be more of the bradykinin, but that's a good question. But the converting enzyme, it can occur, the angiotensin 2 can occur in several other places with regard to not just in the bloodstream or the kidneys, but also in tissues. So, it could be in other places, but I don't think they've related it just to that effect. They've really looked at it as being bradykinin. Some patients will complain of taste disturbances. They may describe what is called a metallic taste in their mouth. One patient said it's like licking an aluminum flagpole. Everybody thought about the Christmas Story, where they dare the guy to lick the pole and his tongue gets struck. We don't like to use these in potassium-sparing people that's on potassium-sparing diuretics, because these drugs can elevate potassium levels. And if you've got a potassium-sparing diuretic, that can elevate it. So one of the concerns would be that we could develop some hyperkalemia, so elevated potassium. And let's talk about the angiotensin 2 antagonist, and then we'll take our break. So the ACE inhibitors first came out, and with the ACE inhibitors, basically, we were blocking the formation of angiotensin 2, okay? Angiotensin 1 wasn't being converted to angiotensin 2. So the other avenue that people were looking at was what is called ARBs, A-R-B-S. These are angiotensin 2 receptor antagonists. So we first came out with a drug called psorallicin, which the thing is that it blocked the angiotensin 2 receptor and was effective. The problem was psorallicin had to be given IV, and it had its duration of action was only like a few minutes. So never could be used clinically, simply because the pharmacokinetics. But they continued to work on these drugs, and as a result, they developed these ARBs. All of them act by blocking the angiotensin 2 receptor. We also learned that there were other pathways that angiotensin 2 can be formed. It is not all of it is formed by going through converting enzyme. So the thing about ARBs were that there are other ways that angiotensin 2 can be formed. And so regardless of how it was formed, the ARBs would block that effect. So the first drug that came out was losartan, and then we had these other drugs, valsartan, candesartan, irbesartan, azilosartan, olmesartan, telmisartan. These have been in the news lately. Does anybody know why these have been in the news? A recall, but also, that's it, Kirsten, is supposedly there has been a potential contamination with a carcinogenic agent. Actually, it's a nitrosamine type compound, similar to what you get with some fried foods and bacon and stuff like that. So losartan and valsartan, so they've been calling them losartan drugs. It's created a shortage because many of these were being manufactured over in China, and the FDA blocked them from being sold because of this. Now, interestingly, a week or so ago, the FDA raised their threshold limit to saying that they were going to allow some losartan that had a certain amount of contamination they felt was not going to be significant, which was sort of an interesting thing there. But these drugs work, relatively few side effects. We've seen some people that have had some GI effects like a little diarrhea and some indigestion. We have seen some angioedema and myalgia. Probably the biggest thing that came up is there's been some lawsuits dealing with these some of these drugs actually producing a enteropathy that's very similar to sprue. So it interferes with the ability of individuals to actually be able to absorb nutrients. But these drugs work pretty well, and in general, it's going to be interesting to see what happens with the losartan and valsartan, and whether any of the other sartans fall into this. But that's going to be an interesting scenario there. So again, the ACE inhibitors block the conversion of A1 to A2, but realize that there are other pathways to form angiotensin II, and the angiotensin II antagonists block the effects of angiotensin II regardless of how it's formed. All right, so let's take our break. This is our big afternoon break. Let's come back at 20 after the hour. And when we come back, we're going to talk about how these drugs are basically used from a combination standpoint, or how we combine them and so forth. So this is going to be a basic, this will be a very basic thing we use on other drugs, in addition to the antihypertensives. So we'll come back at 20 after the hour and pick up on this. Okay, guys, we're back, and let's continue on, and let's talk about combination therapy. So, one of the things that we find is, you may have surmised from discussion so far this morning, is basically is that what we're running into is many times there's not a lot of drugs to treat hypertension that is going to be used as monotherapy, or if they do, they're usually effective in the early stages of hypertension, such as stage one. So most of the time, what happens is that the drugs will work to some degree, but we don't get the blood pressure down to where we want. Or what we may see is the drugs may work. For example, we put you on a diuretic and it seems to work for a while, and then the blood pressure starts creeping up. And so what happens is we start adding other drugs on. Or sometimes we start a drug and we may develop some issues with that drug, side effects. So one of the things that we've done is that has been effective is use what is called combination therapy. And look, first of all, what I want to do is I want you to make sure that you recognize that combination therapy is different from polypharmacy. Sometimes these get sort of mixed. So polypharmacy means too many drugs. Combination therapy, what we're talking about, is a rational use of multiple drugs that will to get the most beneficial effect. Polypharmacy, we see a lot in psychiatry and drug and psychopharmacology, where happens is somebody gives a drug, there's a side effect, so they give another drug to offset the side effect, which creates another side effect, and then somebody gives another drug to offset the side effect of that side effect. Or what happens is somebody is changing the drugs and doesn't discontinue, so these individuals are on a lot of drugs which they don't really need, and may actually put them at a higher risk for adverse events or serious drug drug actions. So, in fact, one of the things I've been proud of psychologists is, going into this prescribing program, all I heard from physicians was, as soon as psychologists get prescribing rights, they're going to be burning up prescription pads. What I have seen, the majority of what I have seen, and I'm talking about the large majority, is a lot of the prescribing psychologists have gone in and actually done an assessment and actually reduced the amount of drugs that have been used. Sometimes it's been these horrible situations where the individual may be on 8 or 10 drugs. There's duplicate therapy and so forth. So we're going to talk about combination therapy, which was probably used first in hypertension control, but has moved to other, to other situations where that the other disease states. Okay, so when we talk about combination therapy, the principles of combination therapy are really are the same across the disciplines or across the disease states. So what our goal is with combination therapy is basically we want to increase efficacy. I probably should have reversed these. So we want to increase efficacy. So we want to get the reason we're going to combination therapy is that we're trying to get a better therapeutic outcome. And we want to increase efficacy and reduce side effects. Okay. We don't like to use combination therapy just to reduce side effects. That's where you start. When you start getting side effects, what you may want to consider is, am I using too high of a dosage, or is this the right drug? But you don't want to get into this thing where that you are basically band-aiding it, so that when you give a drug at doses high enough, you start getting a side effect, and so you start dosing that side effect till you get the side effect of the second drug, and then you put another drug on there. The key is, what we want to look at is the drugs should have different mechanisms of action. Okay, simply adding a drug that has the same mechanism of action is equivalent to just increasing the dose. So what we want to do is we want to attack the problem through multiple pathways. Okay, for example, I don't want to give a diuretic like a thiazide, and if that thiazide doesn't get the blood pressure where I want it, I don't want to add another thiazide, because both thiazides are working through the same mechanism, which means that if I'm getting a side effect, a good chance is it's because I'm getting too much going through that pathway. Okay, and the other thing we hope for. So if we go through different pathways, the idea is that we will be able to attack it. We will also be able to use, typically we're able to reduce the dosages or to use lower dosages, which means less side effects. And then the other thing which we've seen occurs is that many times the drugs can have opposing effects on one or more of the homeostatic responses. What I mean by that is that many times the drugs can actually oppose the side effects by acting or blocking some of the side effect things. And I'll show you some examples of that, okay? So sort of the take-home message for the combination therapy is what we're trying to do is to get a better therapeutic response and actually improve the benefit risk. We want to hope to use lower dosages through multiple drugs going through different pathways and be able to use low dosages, which means a good chance of lower side effects. Secondly, is we want to, if we're lucky, some of the effects of one drug may oppose the side effects of the other drug. So let's take a look at a few of these examples. All right, so here we look at, many of these we will start off will be with a diuretic, because what we found is generally when we start talking about hypertension, if we diagnose it early, a lot of times the diuretic may be able to control it by itself. But eventually, most hypertensive patients eventually will move to a point where we have to add another drug. So the nice thing about a diuretic is it can be used as monotherapy. There's nothing wrong with it. Some of these drugs, like we talked about, the vasodilators, you can't really use as monotherapy. So we typically start with a diuretic, typically a thiazide, and then we will add another drug on to try to lower it. So the first example is, so we have a diuretic, let's say a thiazide, and then we add a beta-blocking drug. Well, one of the things that's happening here is we're looking at two different mechanisms. One, we're acting on the kidney and reducing sodium in water. And then the other thing that we're going to do is we're going to use the beta-blocking drug. So we're acting through the beta receptors, okay? So one of the things that happens is that beta-blocking drugs can lower our basically renal perfusion, and it can act on the renin-angiotensin system, and so we can get some peripheral edema. We can get some edema produced from that, and the diuretic takes care of the edema. We could use a diuretic and a drug acting in the central nervous system, like clonidine or methyldopa, or a diuretic and an ACE inhibitor. Or in some cases, we start going to multiple drugs. So we use diuretic, a beta-blocking drug. That doesn't work. We add a vasodilator. Well, let's take a look at how this can oppose it. All right, so the vasodilator we know can cause tachycardia. Well, the beta-blocking drug would prevent that by blocking the beta receptors in the heart. The vasodilator can cause fluid retention. The diuretic takes care of that. And here on this last one, we have a diuretic plus a beta-blocking drug, plus a vasodilator, plus a CNS acting drug. So here we have multiple pathways. We could do, a beta-blocking drug plus an alpha-blocking drug. We wouldn't want to do, for example, like a beta-blocking drug and labetalol, a mixed acting drug. We wouldn't want to do clonidine and methyldopa. So what we're looking at is different pathways. And again, by hitting the different mechanisms of action, what we hope to do is to be able, since we're hitting it, one way to attack the problem is you hit it with a, with a big sledgehammer, and if we hit, hitting it, really hard with a huge dose, then we may get some bruising that occurs, some collateral damage. Whereas we can sometimes use smaller dosages of multiple drugs, which may actually allow fewer side effects and may actually offset some of those side effects. So if I were to ask you, a possible drug combination, one of the things that would be is that if I would say which one is irrational, is like, for example, if you had 2 beta-blocking drugs or 2 alpha drugs or 2, now you might get 2 diuretics, you would have a thiazide and a potassium sparing drug. So sometimes they'll do that because they act a little less, and you can use low doses and try to maintain potassium. But you don't want to use propranolol and metoprolol. Even though they're slightly different in their beta blocking activity, they're both going to have effects on the beta receptor. So does anybody have any question? One of the things I want you to think about tonight when we break, you know, in a little over an hour from now, is I want you to think about some of these, just look through these mechanisms and see if they make sense to you, okay? All right, so let's go to another group of drugs, and this is sort of a transitional group of drugs because the calcium channel antagonist, and by the way, I've got probably about 4 or 5 videos that Marissa she's probably already got them posted, that show some animations of how these drugs work. Some that we've covered today, most of what we covered, a few that we've covered today. And then what we're going to do is basically, you'll have one about dealing with nitroglycerin, which I don't know if we'll get to it today or not, but we will be getting to it in the morning. All right. So I call these calcium antagonists sort of a transitional because they are used for the treatment of hypertension, but we also see that they're used for the, in addition, for a lot of other drugs, a lot of things like, for example, angina and atherosclerotic. So we have a lot of calcium antagonists out, but I want to show you something here that's sort of interesting. So we have actually this drug, verapamil, which, by the way, with calcium antagonists, this is a drug that's used for sort of as a fourth line agent for treatment of schizophrenia. So you might see calcium channel blockers as something that you would prescribe. But what we find is most of these calcium channel antagonists really fall into 2 categories. We have verapamil, and then everything else basically is very similar to these 2 drugs, which is nifedipine and diltiazem. So we see a lot of amlodipine used now. So we see different places, but nimodipine, nicardipine, isradipine, amlodipine, all of those. Those are all, and all of them are very similar to nifedipine. Okay, so verapamil seems to be the red-haired stepchild here. So it's a little bit different in what happens with it. Regardless, all of the calcium channel antagonists, and I'm going to come back to the differentiation of why verapamil is different than the others, but the calcium antagonists, their mechanism of action is exactly what the name says. They interfere or they antagonize calcium, okay? So what they're going to do is they're going to inhibit calcium influx. They're going to block the calcium channel. So sometimes they're called CCBs, calcium channel blockers. So one of the things that's interesting is that these calcium channel blockers have a lot of variation in their structure. So what that suggests to us is there's either multiple binding sites in the calcium channel, or there may be some nuances as to why these drugs, the different structures work. But in essence, and there's a video that you've got that shows calcium channel blocking mechanism, but basically just think of it as a plug in the calcium channel, okay? So one of the things that we see is, think of the cardiovascular system, the places where calcium is required, and it's a lot. So one of the reasons they work for hypertension, and one of the reasons they work for coronary artery disease, is because calcium causes contraction, and contraction of the smooth muscle cells causes the blood vessels to get smaller, which causes peripheral resistance to go up and your blood pressure to go up. So if we reduce the amount of calcium coming into the cell, that's going to decrease the amount of vasoconstriction, okay? So reduction of this calcium signaling, basically by blocking calcium coming into the smooth muscle cell, that's going to produce vasodilation. So it's going to open up the blood vessel, okay? Now, we do know with a lot of these calcium channel blockers that when you, at really high doses, several of them will also produce alpha blockade. Typically, the doses that we're using, we're not going to get that, and we don't really need it, but the alpha blockade may, worst case scenario is the higher doses, we may get more vasodilation, so we could possibly have a little bit more hypotension, so that would be a careful. But like I said, is that if you look at the structures of these calcium channel blockers, they are very diverse, which suggests that they're not only may they have multiple binding sites in the calcium channel, but some people have even suggested that they may have other actions, which we really haven't gone into, but people are looking at those. So interestingly, with these, we do see there is some tissue selectivity, which is, if you think of all of the tissues that require calcium, it's pretty much every tissue in your body. I mean, you think about it, your nerves require calcium. Most contractile cells require calcium. Most cells have some need for calcium. So one of the things when these calcium antagonists came out, one of the big things was basically they're going to affect too many tissues. How can we have a predictable therapeutic response if it's blocking calcium channels everywhere? Calcium channels in the brain, calcium channels in the heart, calcium channels in the blood vessels. For some reason, could be structure-activity relationship. I don't really know the reason, but we do know that there is some degree of tissue selectivity, which means that there is some tissues that seem to be more susceptible to the action of these drugs. Fortunately for us, one of the drugs is, or one of the tissues is the blood vessels. So therefore, the blood vessels seem to be more sensitive. One of the reasons may be when the calcium is given, for one of the first place it does is gets taken up in the bloodstream. So that may be one of the reasons, but which means that we can have some degree of selectivity. Now, if we give a whopping dose, that's a pharmacological term, means really big dose. If we give a huge dose of calcium antagonist, it's going to distribute much, in a lot of different places. So what we do see is that most of these drugs, their effect, the blood vessels seem to be more sensitive. Now, here's where we see a little bit of difference. Verapamil differs from most of the other calcium channel blockers because it seems to have the greatest effect on cardiac conduction. Okay, so what we find here is that the electrical properties of the heart seem to be very sensitive to the effects of verapamil. This could be a structure-activity relationship. I don't know. This cardiac conduction effect is called a dromotropic effect. It's really not specific for cardiac. It's dromotropic, means deals with nerve conduction. So what this means is verapamil is more sensitive, or the heart is more sensitive to the effects of verapamil than it is to the others. The other calcium channel blockers, we see that the blood vessels are more sensitive. And if you look at the three that I gave you, the difference is verapamil has more cardiac conduction effects. And in fact, verapamil was actually introduced into the United States as an antiarrhythmic drug. So we will touch on verapamil and even some of the beta blockers when we talk about antiarrhythmic actions. So verapamil tends to have a greater effect on the conduction of the heart than the other. And when we look at diltiazem, the reason I put that one there is diltiazem seems to be one of the least potent effects. And so one of the things that we see with diltiazem is basically that if we want less side effects, diltiazem seems to be the better choice. Nifedipine seems to be pretty good, and diltiazem seems to have the least effects. But we have to keep in mind that in different people, diltiazem may still produce some side effects. So in general, we typically said verapamil, if you want more effects on the heart, nifedipine is going to be more effects on the blood vessels, and most of the other calcium channel blockers that I had listed are going to be very close to nifedipine. Diltiazem is like nifedipine, or has action similar to nifedipine, but it just seems to be not as potent. So it tends to have minimal side effects. So what do we use these for? And again, as I said, this is sort of like a bridging agent or transitional agent because it affects. We've seen these used in hypertension. So we've been talking about most of today dealing with the antihypertensive drugs, but we've also seen these used in angina. So basically in coronary artery disease, we see that calcium channel blockers can be used. We've seen them, verapamil in particular has been used for treatment of arrhythmias, which we will talk about tomorrow. And we also see them used in Raynaud's disease. I don't know if you remember when we talked about Raynaud's disease, but this is the disease that it occurs more frequently in women, affects the hands, the feet, especially the fingers, the toes, can affect the nose, the ears. What they develop is a severe vasoconstriction, so the blood vessels constrict, get very small. The individuals, their hands, it's very painful, can be brought on by the cold. And what happens is the blood vessels in these extremities just vasoconstrict, and because the tissues become ischemic, it's very painful. And so we use this to relax those blood vessels. So calcium channel blockers have been used for that. And then we've also seen them used in hypertrophic cardiomyopathy. One of the things we use these drugs for is sometimes is to basically reduce. Basically, what we do is vasodilate the blood vessels, which drops blood pressure, which means the heart doesn't have to work as hard. So hypertrophic cardiomyopathy, what's happening is the heart has hypertrophied. It's gotten bigger because it's working so hard to pump against the blood vessels. And as a result of that, basically, we can reduce the afterload is what we call it. And that results in the heart not having to work as hard. Okay. The side effects of these drugs, actually, they are pretty good. When they first came out, one of the big things that people were concerned about was that, like I said, you've got so many tissues that require calcium that one of the biggest concerns was that what are we going to do with these if all these tissues suddenly don't get enough calcium, or we interfere with calcium with these tissues? And so that was our biggest concern. And again, we've seen that it produces, there seems to be some cardioselectivity. And but we still have an issues, and these are usually dose dependent. So what we're concerned about is, one, is cardiodepression, that we decrease the calcium going to the heart so that the heart doesn't beat as hard or beat as fast. Hypotension, again, these are all extensions of the pharmacology. So that's an issue that can occur, is that we get the blood pressure gets too low, we get too much of a drop in blood pressure. One of the things that's sort of interesting is we do get some peripheral edema. We know why it occurs. We know that when the calcium channel, when we decrease blood pressure, is that we're going to decrease renal blood flow, and therefore the kidneys are not going to be filtering as much fluid, or going to be a little slower in filtering fluid. So just like with any other drug that causes a drop in blood pressure, we can get peripheral edema. The interesting thing about this is a lot of times the peripheral edema does not appear to be responsive to diuretics. Now, with a lot of drugs, what happens is if we get some peripheral edema, we basically give them a diuretic, and the diuretic gets rid of the extra fluid, and that's it. But several cardiologists that I talked to said that if you put a diuretic on before giving the calcium channel blocker, what you will do is you don't get it'll take care of the peripheral edema. You don't really develop it. But if it develops and then you add the diuretic, sometimes it's not responsive to the diuretic. So some people say, well, why should we not just put everybody on a calcium channel blocker, go ahead and put them on a diuretic? Most people, usually that's the case. They're already on a diuretic. But there are a few people that may not be on a diuretic, and this develops. So that's one of the things that has come about. And again, why it doesn't develop, why it isn't responding to it, I have no idea. You would think that it would basically respond, but it doesn't in some patients. Other things that we've seen with regard to these as far as side effects, one thing is we've seen some GI, some complaints of dyspepsia. We've seen some constipation. Some people have complained of headache. That's probably due to the vasodilation in the brain. And we've seen also just some minor type things, facial flush, some tingling or burning. Most people are basically able to tolerate the side effects that we typically see with the calcium channel antagonist. And typically what we find is that these calcium channel antagonists, these side effects are dose related. So again, by keeping the dose down, there's no problem with it. And when it does develop, then what we typically are going to do is we will typically just simply decrease the dose, and that usually is what handles it. A nice thing about them, they don't alter blood lipids. Some of the other drugs can raise your blood lipids, and especially if you've got high cholesterol, sometimes that can be a problem. These drugs, a lot of times, actually have less effect on the kidney than a lot of other drugs. So that's it. And a big thing with the calcium channel blockers is they don't interfere with exercise. The beta blockers, a lot of people don't want to stay on those because that it's hard to keep their heart rate. People that exercise, a lot of times, they're so focused down on getting their heart rate to the heart rate max. And when you're on a beta blocker, the problem is that you can't ever get back up to that same max. So people don't like them. But calcium channel antagonists seem to, people that, that are active in exercise, it doesn't seem to be a big issue. Sometimes they will produce a slight natriuresis, which means that you excrete sodium. And that is one of the things that is pretty good from a standpoint of, especially with somebody with hypertension. Okay. Now, we do have a concern with verapamil and nifedipine have been shown to increase digoxin levels. We'll talk about digoxin in a little bit, but you're not going to see a lot of digoxin prescribed. But one of the things, since you could potentially prescribe verapamil, that I do want you to be particularly aware of is this. There has been a drug interaction with verapamil and beta blockers, okay? One of the things that happens is verapamil, like I told you, has a dromotropic effect, which means it can slow cardiac conduction. That means it can slow heart rate. So if you combine verapamil and a beta blocker, you can get some pretty severe cardio depression, okay? It seems to be more than simply additive. It seems to be synergistic. So you have the calcium channel effect on the cardiac conduction, which is slowing cardiac conduction, and then you're blocking the beta receptor, which is the autonomic drive for that. So the combination of the two can produce some very severe cardio depression and bradycardia. It can be life-threatening. We actually saw some of these interactions occurring because here in Athens, we would see somebody being treated for high blood pressure and was be given a beta blocker for their blood pressure. And we had people that were going to Atlanta that were seeing cardiologists for their coronary artery disease. And we've had a couple of pharmacists that actually caught the interaction because of the general practitioner had been prescribing the beta blocker. We had an older gentleman that went over to Atlanta, and the doctor started him on verapamil, actually started him on verapamil because of an arrhythmia. And the doctor, this is when the verapamil first came out, and this was not a well-known interaction because the drug had just been out, but it was starting to show up and being written up in the literature, and the guy happened to get his prescription filled at the same pharmacy. So the pharmacist actually caught it because when he went to fill the verapamil prescription, it flagged and said potential major interaction. So they were able to prevent this guy from taking both of these drugs. So what they did was his cardiologist used a different antiarrhythmic drug than verapamil, and so that prevented it. But since you might be potentially prescribing verapamil to treat somebody for a mood disorder, schizophrenia, is if that interaction was there, and you could, some of you may be doing PTSD, and beta blockers are being used, and you could have somebody on verapamil. It theoretically could occur with the other calcium channel blockers, but it didn't occur simply because, excuse me, it doesn't occur as much because the other drugs don't produce the cardio depression. They don't have that direct effect on the cardiac conduction system. Okay, let's see. Let's do this because I want to do one more. Y'all got your quiz, but I want to let's take a let's come back on the hour. So that's going to take you about 8 minutes, and I'm going to try to send a case study to Marissa. I'm going to send this to you in just a minute if I can pull it up. I should have sent it to you earlier, and I want you guys to see if you can pull up this study because I want to point out something to you. Just work through this. It's dealing with a patient with high blood pressure. So Marissa, give me about 2 or 3 minutes and I'm going to send it to you. And then if you will post it, and the rest of you go ahead and take your break. But when you get back, if you could just pull it up on your computer, or I'll try to pull it up on my computer, you can follow through with this because it demonstrates a few things here. Okay. So we'll start back officially. I'm going to send you the case, I think, but if not, I'll at least have it up on my computer and you guys can sort of follow it. And it deals with some issues associated with the ACE inhibitors and things we've talked about. Okay, so I will see you guys on the hour. So you've got about 8 minutes. This will be our last break today. And Marissa, as far as the other, as far as the next 4 questions, we'll probably get to them. That'll be we'll leave them like we did last weekend. Is we'll give them like 20 minutes or so before 25 minutes before the end of the class for them to do those, and then we'll go over those tomorrow. Okay. All right. So take a break. I'll see you guys back. And Marissa, I'm gonna try to send that to you right now if I can pull it up. Okay, I could not get this case study up to where I could get it and send it to you. Can you guys see the case presentation form that I've got listed here? Okay, so I want to go over this just to show you. It's just to illustrate some things that we have, and it fits with the ACE inhibitor, but it points out a few things here. So if you guys will just sort of follow through with me. Um, I didn't give you this case study to work up because, again, there's a lot of stuff that you guys would not have had. So what we have is this is a case that we developed for our students that we did in in one of our labs. And so I've just sort of followed through here with me, if you will. Let's see. I can't get it to go full stream. But just I'm really putting it up here so I can read it and go through. So here we have a patient. He's a 60-year-old African American. You really can't see anything. I was afraid that was the case. I can't blow this up. So just follow with me, if you will. And I've got this up mainly for that. So just follow. So I've got a 60-year-old black male that shows up. He is his chief complaint is basically he checked his blood pressure at the pharmacy last week, and it seems to be running high. So that's his chief complaint that he shows up with. Okay, so if we look at this, he's basically had several high blood pressure readings that he's got at his local pharmacy. He's gone to his primary care physician, who has recently adjusted his blood pressure medications. He was originally on lisinopril, 20 milligrams per day. And basically, they bumped his lisinopril up to 40 milligrams per day. And he's concerned that his blood pressure is still running high because he's gone to the pharmacy since seeing his clinician. He says that he thinks his blood pressure is elevated, or is still staying elevated because he recently moved to a new residence. He started a new job and had a higher level of stress. He stopped exercising while he was making the transition to his new job. Started eating out more because he just didn't have time to cook for himself. So he's eating a lot more fast food. He wants to lose some weight. He's trying to walk more frequently, but is only being able to walk like 15 to 20 minutes every 2 to 3 times a week. So his blood pressure readings at the pharmacy have ranged from 158 to 74 systolic and 82 to 98 diastolic. So he's definitely hypertensive. Okay. He's been having a lot of frequent headaches. These have been occurring about 4 to 5 times a day, 4 to 5 times a week. And he takes Excedrin migraine and doesn't seem to be working. But he still takes it because he keeps hoping it'll help. He hasn't been dizzy, has no shortness of breath, has no chest pain, no edema. He's had hypertension for about 14 years, and he's got chronic kidney disease he's had for about 8 years. Okay, so at the visit, we see his blood pressure is 162 over 94, so he's hypertensive. He has a family history. His mother died, 69-year-old. She had high blood pressure. She had coronary artery disease. She had diabetes. She had chronic kidney disease. His father has hypertension and prostate cancer. His brother has hypertension and is obese. And basically, he smokes 1 pack per day. He drinks 2 to 3 drinks, 1 to 2 nights per week. Denies marijuana, cocaine, or other drugs. He drinks 2 cups of coffee every morning and then another with lunch, so 3 cups of coffee. What we see with his labs, we see his potassium is elevated, we see his serum creatinine is elevated, we see his glucose is elevated. So we look at his meds. He's on lisinopril 40 milligrams, as I said before. Basically, that has been a recent dose increase. He was at 20. He's taking Excedrin migraine for headaches as needed 4 to 5 times per week. And so what we've got is a patient here with uncontrolled hypertension, headaches, smoking, obesity, hyperkalemia, chronic kidney disease, and an abnormal glucose reading. Okay, so that's our primary list. Now let's just go through these because I want to point out something to you. So let's start with his uncontrolled hypertension. Well, one of the first things we want to do, we know he's had an increase from 20 to 40 of lisinopril. And we know he's still getting he's had several high blood pressure readings at his pharmacy. And when he comes into the clinic, we see that he's still got a high blood pressure reading. He attributes it to his change in life that's occurred. And we are concerned about his labs. So first of all, first question, what do you think the first question should be to this patient? And I know you don't have the case right in front of you. Exactly. Jason, you hit the nail right on the head. First question is, are you taking your medicine? And not only are you taking it, but are you taking it correctly? Okay. So that is our very first question that should start off. If we know he's got high blood pressure, we know he's been treated for it. So one of the questions is, are you taking it? And then one of the things you might do is, tell me how you take it. So one question is he taking his med? That should be our first question that's coming out of there. Okay. Now, we know that he's got some other issues going on. We know that there's a lot of lifestyle changes that have probably attributed to, stress, lack of exercise. We would like to make him, talk to him about stopping smoking. His alcohol drinking, if he's being truthful to us, is not major issue, but with his other problems, that would be something we would look at. But another thing is he's taking in a lot of caffeine because he's drinking 3 cups of coffee. We don't know how big those cups of coffee are. We don't know how strong those coffee are. But the other thing is he's taking Excedrin migraine. Excedrin migraine has caffeine in it. So he's getting, 3 cups of coffee a day plus this. Caffeine can raise our blood pressure. It doesn't seem to be helping anyway. So one of the things is we want to probably get him off the Excedrin and probably get him back from drinking as much coffee. So let's go back to his hypertension. All right. So one of the questions is they increased his 40 milligrams. So they doubled his dose of lisinopril. So one question is his blood pressure is not going down, but one of the things would be is that, so the 40 milligrams doesn't seem to be being efficacious. So one thing we may need to consider is whether we are going to add another agent, okay? And there's guidelines that go through and tell us what to add. With an African-American, probably we would use one of the calcium channel blockers like amlodipine, okay? We're not going to give him a diuretic. And one of the reasons he may not be on a diuretic is, remember, exactly, different mechanism of action, calcium channel blocker. We're not going to necessarily take him off the lisinopril, but look at this. He's probably been taking his lisinopril because his potassium has gone up. And one of the things that the ACE inhibitors can do is they can elevate your potassium. So we don't know whether that is due to him taking the higher dose, or a lot of the salt substitutes. When people are hypertensive, they tell them use salt substitutes. Does anybody know what's in many of these salt substitutes? So salt is sodium chloride, and some of these salt substitutes are potassium chloride. So we don't know if he's been eating more potassium-rich foods, and that's why his potassium's gone up. It's not huge, but it has elevated. But it probably may be related to the lisinopril. So one of the things we may want to do is we may want to move his lisinopril back to the 20 milligrams and add a different drug. And in this case, the recommendation would be amlodipine. Now, one of the things would be, well, why not put him on a diuretic? And that's what I was getting to, is one of the big things with the diuretic is he's got chronic kidney disease. So you don't want to add a diuretic there. So we go to a different drug there, okay? So one of the things we have here is that we need to know whether he's taking the medication, and one of his lab values is abnormal. And one of the questions is that lab value abnormal because he is taking this drug, which has elevated his potassium, okay? So that, or is his diet changed? So we probably are going to drop him down to 20 milligrams, back to where he was. We didn't have potassium problem then. We're going to educate him about taking potassium-rich foods, make sure that's not an issue. And then we're going to add another drug with a different mechanism of action. So I'm not going to add, a different, I'm not going to put another ACE inhibitor on there. I'm just going to use a different mechanism. So Eddie, as you said, is basically we're picking something else. And in this patient, if you look at the guidelines, calcium channel blocker is recommended, okay? So that's an interesting thing, whether is we need to know he's taking his medication, and then it looks like he may actually be taking his medication, and when we increase the dose, we didn't get any increase in efficacy, but we did get his potassium going up, and elevated potassium could be a serious thing down the road, okay? The other thing is he's taking all this caffeine in, and he's taking the Excedrin migraine. This is one that you might get with some of your patients, is they're complaining of headaches and so forth, and they're taking this drug. What I would do is probably move him, we'll tell him to go off the Excedrin migraine because the caffeine, and I would probably move him to tell him to try Tylenol. And if the Tylenol doesn't work, then one of the things that we would do is probably, if it's still continuing, his headaches may be due to his blood pressure not being controlled. So if we get his blood pressure controlled, that may take care of it. But let's say we get his blood pressure controlled, he's still having headaches. We're going to send him to his a healthcare provider, a neurologist, or something to look into the headaches. Okay. Let's see. There was a couple other things I wanted to point out to you in this case. It just had some interesting things. So the hyperkalemia is a concern, and we want to make sure whether that's possibly the drug. Now, he has an abnormal glucose reading of 199, so that's elevated. One of the things is we don't know if that is if that's a fasting glucose. I can tell you that his appointment was around 1 p.m. So it's right after lunch, and so it's possible he ate a lot. This was elevated. So basically, what we want to do is, since his mother had a history of diabetes, he's got high blood pressure and chronic kidney disease. Diabetes is not something we want to do. So what we may want to do is we're not going to put him on a drug to control his glucose yet. We want to probably bring him back in and determine whether if it's a true we want to get a fasting glucose on him. So, but the reason I wanted to show you this case is that here we have a situation where that an increase in dose didn't appear to be efficacious. He appears to be taking the medication as required. The fact that his potassium went up, my gut feeling is that it was probably drug induced. So when they increased the lisinopril, I think we had probably maxed out. And actually, I can tell you that this was based on a real case of a colleague of mine. And I can tell you that we know that it wasn't controlling his blood pressure anymore. So by increasing the lisinopril, we didn't get any efficacy, and we started getting a concern with hyperkalemia. So lowering back down to 20 milligrams and try a different drug, which is what they did, and that did work. So that's a big issue. I mean, that's just what I wanted to primarily show you guys with that. Okay. All right. Let me go back to, I may lose you and I may have to come right back on. I'm going to go back to the slides. Okay. So now that I got you back on here to the slides, and let me get you to slide thing is there. So just to get, that was sort of just to give you an idea of how we would, of things to be thinking about there. Okay. All right. So what I want to try to do is let's get through a few of these statins. So we're moving from hypertension. Now we're moving into coronary artery disease. And this is a big one, and you're going to see a lot of different drugs here. So when we look at atherosclerosis, our number one thing that we're going to do is, of course, we're looking at cholesterol levels and LDLs. Those are the labs that we're going to be looking at. One of the things that we're going to think about, and from a standpoint of this, is that we want to, first of all, we know that most of our cholesterol is going to be coming in to us from found enough. We know that it's mainly diet. Okay. Now we do know that there's some genetic components there, but we know that one of the big things we want to do with people with atherosclerosis is going to be, you're going to need to clutch, you're going to have to alter your diet and cut your cholesterol down. Okay. And we also know that many times that there are several patients that will work. And so from a standpoint of, we know that some people will be compliant, some people will not be. There are a group of people that will be compliant and non-pharmacological methods will work. But many patients we know are going to have to go on to medication to try to handle this. So we have a number of drugs. Some of these you've probably heard of. Definitely you've heard of the statins. But we have bile acid sequestrants. We have the statins, which actually they inhibit an enzyme in cholesterol synthesis, HMG-CoA. We have drugs that are classified by fibrates. We have these drugs that are, some people call them fat blockers. They basically inhibit the absorption of cholesterol. We have niacin, which is a vitamin. And then there's other drugs that may have an effect. Even estrogen, one of the things that seems to be beneficial is that estrogen may help sequester, may actually help sequester any, oxidation components. So let's start off with the bile acid sequestrants. And so we have three here. They're cholestyramine, cholestyramine, and cholestyramine. These drugs, what they're going to do, the name of their classification basically tells what's happened. So if you remember back with digestion, so you remember that the bile duct goes down and it enters into the small intestine in the duodenum right next to the pancreatic duct. So the bile is stored in the gallbladder and then it is secreted. It goes into the GI tract and it helps us absorb fats. And so what we're going to see is sort of a common mechanism here is that bile is going to have, is derived from cholesterol. So what's going to happen is take a look at this situation. So what's going to happen here is that these drugs, when you take them orally, and when they get down there in the small intestine, as your body is secreting bile to help you absorb fats, these drugs basically bind up the bile. Now, typically what's going to happen, the bile will bind with the fats and then it's sort of absorbed. So this is blocking that. So what's going to happen is it binds to the bile fats, bile acids in the intestine. And as a result, the bile is not reabsorbed. What happens is the bile actually gets excreted in the stool. So what this means is your body is producing bile. It is using cholesterol to produce bile. So one of the things that's going to happen is as you get rid of the bile acids, whereas we used to reabsorb them, now what's going to happen, you're losing them. So what's going to happen here is your body is going to start taking cholesterol and making bile, which, think of it like this. The more cholesterol that you have floating around in your bloodstream is, think of it, if it's floating in your bloodstream, it can stick to the walls of your blood vessels. But if we reduce the cholesterol, so instead of it floating around in our bloodstream, we are getting rid of it. That means we have to make more of it. So that's going to mean there's less floating around in the in the blood vessels. So there's less to stick and make a plaque. So what's happening here is your body, these drugs are basically trapping the bile, not letting it being reabsorbed. You excrete it in your stool. And then what's going to occur is basically your body is taking the cholesterol that was in your blood and it's now pulling it out of there and putting it in your, making bile, okay? So this increased diversion of cholesterol to bile means there's less floating around in the, bloodstream, okay? So as these intracellular cholesterol pools decrease, what's going to happen is you have these LDL receptors that are in the liver. Okay, so what's going to happen here is going to be that because our cholesterol goes down and there's not enough that level goes down, the body starts making more LDL receptors. They express those on the liver cells, and when they express them on the liver cells, basically what's going to happen is that these LDL receptors will then trap the LDL and pull it out of the blood. So again, the net effect is what we're doing with a lot of these procedures is we are basically decreasing cholesterol that's floating and LDL that's floating around in the blood vessels, so they can't stick to the wall. Okay. So what happens with these bile acids? Normally, we produce the bile acids. The bile acids are secreted down into our small intestine, help us absorb fats that they get picked back up and get reused. But now what's happening is the bile acids bind them up so they can't be reabsorbed, and you excrete them. So now your body starts making more cholesterol. And because you've got a less cholesterol to make bile, then you increase these LDL receptors to try to pull the cholesterol out. So the net effect is what we're doing is we're pulling the fats out of the bloodstream and putting them in the cells to be used for cholesterol synthesis. Okay, we're going to see that that's going to be sort of a common mechanism that is occurring with a lot of these drugs. Is basically by diverting cholesterol, it makes our body make more LDL receptors or express more LDL receptors. The LDL receptors pull the cholesterol and the lipids out of your blood and put them into the liver so that they can be used to make some of these components. There's no way that we can go to zero cholesterol intake, because cholesterol is used to make steroids, it's used to make cell membranes, it's used to make a number of things. All right, now, the nice thing about this is that because this action is occurring all in the GI tract, it's not being absorbed. These drugs really aren't being absorbed. You're taking them, they're staying primarily in the GI tract. They're not being absorbed up, or if there's any that's being absorbed, it's very little. Pretty much what they're doing is trapping the fat in the GI tract and not letting it be absorbed, which then just gets carried right on out through the stool. Okay. So that's a big plus, is the fact that we are not having any systemic effects, or very minimal systemic effects. That's good. Okay. The downside of it is really one of the big issues is that most of the side effects that we get are all because of the effects in the GI tract. People complain of constipation. They have a lot of gas, sometimes abdominal bloating or discomfort. And the other thing is these drugs really are not really palatable. They just don't taste really good. We like using these in kids a lot because we don't get the systemic effects. And one sense too is that parents can sort of hold the kids down to make sure they take it. Now, the big thing that I want you guys to be aware of is this point right down here. These drugs can bind with other drugs. Okay, so here's a concern. And especially you've got lipid-soluble drugs, so they should be able to do them. So what you have to do is, it's very easy for a lot of people that are taking multiple drugs. It's very easy for basically people want to take all their drugs together. So you sit down, and in the morning before you go to work, and you basically grab the drugs you're going to need to take for the morning, you take them, and then you take the next ones at night or whatever. So, but here's the problem. Since these drugs, these bile acid sequestrants, can actually tie up and bind the drug, which means they won't be absorbed. So you won't get a systemic effect, or you may get less than what you expect. You have to either take the other drugs an hour before. So think about it. In the morning, you're going to, let's say you're trying to leave the house by 7:30. That means that basically, you get up and maybe take your cholesterol drug, your bile acid sequestrant, at 6 in the morning, so that at 7 or 7:15, you can take your other drugs. But let's say you get a little bit late. So the alarm clock, you just didn't want to get out of bed. It was nasty outside. So what happens is you get up, you're pushing late. So it's now 6:45. You got to be out of the house at 7:15. So one of the things is then if you take your bile acid sequestrant, then you got to remember to take your other drugs an hour later. If you mess that schedule up, then what is recommended is that you take it 4 to 6 hours after. So one of the big problems with this is patient compliance, because the patient compliance is they will either forget to take it, and not take it. Or the other thing that'll happen is they'll go ahead and take all of them together. And then you may have, this is where you worry about where the patient's taking them all together. You don't think the drug is working, so you up the dose, and then the patient decides or gets re-educated, starts taking it right, and starts having side effects of the other drugs. So that's one of the big issues with these bile acid sequestrants is side effects are typically, they're not pleasant. They're mainly GI, but there's nothing that's really life-threatening in a way. But on the other hand, the compliance and the effect on other drugs is a big issue. All right. This is a good place to stop because I want to spend some time on statins. So here's what we're going to do is number one is that Marissa's going to put up the short quiz for today's questions in just a moment. So take the quiz, and then she also has posted, there is a set of videos that talk about mechanism of action of several of these drugs. I've included nitrate, the nitroglycerin drugs, which we'll talk about tomorrow. Tomorrow morning, I'll have a video up, I think, of the statins and some of these drugs so you can visualize how they work. But there's about 4 or 5 videos. One's on ACE inhibitors, I think calcium channel blockers. They're fairly short, but they're good. So let's call it a stop today. Tomorrow, we'll pick up on the statins. This is where we'll start. First thing we'll do tomorrow is I will go over the answers to this afternoon's quiz. Does anybody have any question? The other thing I would like for you to do is take a look of and maybe write out under these combinations. And tomorrow, maybe, send me those combinations. I'll ask you for them, and you can just give me the combinations that you picked up, and we'll just talk about those in general. Does anybody have any questions? All right, Marissa, you can go ahead and do the test. The 4-question test, and I will go over these answers with you guys in the morning. You guys have a good evening, and I will see you at 9 in the morning.